Yeah, but it is nevertheless, you can argue about how to define the vulnerable patients, and we can come back to that, how to define the vulnerable patient. But it was the goal to identify, and we will not go to 20 years or 30 years old people to look for vulnerable patients defined in this way. We also agree on that. But then we could get, well, maybe we should expand the shape concept, and it what we are doing now in some way, but we should agree on it. And in fact, Mort has been very strong about the vulnerable patients. He wants to go for the vulnerable patient. It has been the goal for so long time, and we don't look for vulnerable patients at 30 years old people. So it's a reason. But maybe we can discuss it later. But where should we look for the vulnerable patient? How should we define the population at risk where we have vulnerable individuals? And we say, well, we will start screening all men about 45 and all female about 55. And why did we say that? We did say that because the first heart attack, according to American Heart Statistic, is very rare in men below 45 and in female below 55. It is rare. And deaths due to ischemic heart disease, 96% of all deaths from coronary heart disease or stroke occur in people aged 55 and over. It was the people behind the polypill concept. It was the reason they chose age 55, where everybody should take a polypill. So I would be provocative and say, if you have an effective treatment and you can identify those who need the treatment, then we can wait screening until 55 years. And you will be able to prevent nearly all deaths from this disease. In principle, it's provocative. And if you have such a kind of treatment, why should we start down here if you can prevent it up here? We cannot. So in fact, we need in some way to find a good compromise and combine the approach by going hard in here to find the vulnerable patients up here, but start low here by some general recommendations at the society level and so on to prevent people to reach this level where they need an intensive treatment. Yes?
I think Dr. Fuster.
Yeah? Okay. Then we have defined the population at risk. And then we need, is there some people we right away up front can exclude? We don't need to screen these people. And just going to existing guidelines in the NCEP guidelines here, it is said they have a lower risk group here. Almost all people with 0 or 1 risk factors have a 10 years risk less than 10%. And 10 years risk assessment in people with 0 or 1 risk factor is thus not necessary. So they have in this algorithm or this guideline, they have a group, they also say we don't need an extensive risk assessment. If there only is 1 risk factor, they go to the lower risk group without a Framingham scoring. There's other people that has identified a low risk group. This paper in JAMA by Stamler some years ago, they identified also a low risk group. And in this low risk group, there is no risk factors at all. And there is no pre-hypertension, so they have even a lower blood pressure than is the level 140, about 90, that counts as a risk factor. And in this group, unfortunately, less than 10% of the US population belong to this group. But it was, in fact, a very low risk group. So with this risk profile, it has a very high negative predictive value. So if you have this risk factor, your risk of having a heart attack is extremely low. So it is an even lower low risk group than that identified by the National Cholesterol Education Program. And it is in fact this low risk group that is endorsed by the American Heart Association and the American College of Cardiology at a blood pressure that is even below the pre-hypertensive level. It is a low risk group, and they originate also from the Framingham. It is the top on each of these is the low-risk group that all other groups are compared with when the relative risk is calculated. And we have suggested in the SHAPE guideline we should use this very low-risk group upfront to exclude people that don't need to be screened. What do you say? No, we will put the family history also in there. Of course we will that. But nevertheless, the data are here, even though they did not have family history. Without having family history, it was a very low-risk group. We are afraid by putting too many criteria in here. You have a a cholesterol that needs to be below that, a pressure below that, no smoking, no diabetes, no family history, no metabolic syndrome, and so on. You end up with no people in that group. And then you can screen all of them. So we could use them relatively or in absolute term. When the vulnerability have reached a certain level, then you have a vulnerable patient. And I would prefer, and have discussed it also with Mort, not to use the term vulnerable patients for a whole population in primary prevention. They are not patients. But instead call them vulnerable individual. Not make them to patients. You could make them to patients when they reach here. But up here you could say they are vulnerable person or vulnerable individual, and when they have reached a level where they need intensive treatment, then of course they become patients.
One problem, Erling, is you're making the assumption that people progress from moderately high risk to high risk to very high risk. A lot of people die in various stages of that before they've reached the so-called high-risk category.
Yet die of what?
Coronary vascular.
Of a heart disease. Yeah. I don't know how many from this group will in short term be vulnerable patients, how many from this group in short term will go up, but some will, yes. I don't know if we have any data that will tell how many of the vulnerable patients. It's the reason, in fact, I have put this arrow out. It does not go through this one. Can you see it?
The other issue,
but I think it is out there.
The other issue we have to cope with, if you're dealing with a 10-year risk, then it is a prerequisite then to have regular checkups of people to determine when they reach the high-risk category. And if you only have one crack at them, you're never going to be able to identify the next phase.
Well, that's why we have 5-year risk.
Yep.
Every 5 years we have to reassess.
They are reassessed every 5 years.
Yeah,
That's tough.
Yeah, it is tough.
Yeah, but it's in the algorithm. It's reassessment every 5 years.
Yeah, it's even more moderate.
That's asking even more than a one-time.
Yeah, that's true. And the 5 years is even more modest than cancer screening. One other thing is, Erling has alluded but didn't finish it. We really decided to not tag vulnerable patient at this stage because we are short of data to a certain risk level percentage because we don't have the tool to act. So it is still as a conceptual, as I said to Dr. Fuster. The more you go toward the top of the pyramid, the more you are vulnerable. Dr. Brownwald tends to agree to put very high risk group, which is this group, as vulnerable. And he said, you can call it vulnerable, let's call it very high risk. But because this is a new category, we didn't have it before in our definitions. But let's just keep this conceptual until we come to a very peaceful mind. We have already created a lot of fronts for fights. We don't need to fight over this one. Whereas this is a conceptual, and we agree. But these are exact categories. Now, the answer to the question, how many people from this one will have a heart attack in the next year or 5 years? How many people from this one, how many? We don't know exactly, but we know here is a lot more than here, the ratio or proportion, and it's a lot more than here. That's what we call it moderately high risk, and very high risk. Once we come to end of 10-year study, perhaps after MESA come out, and we have really time to digest and chew every part of MESA, we might be able to put numbers here, which would be great. And that's what we
have some preliminary data on that for EPT, do we not?
Well,
information on that not only the magnitude of the scores associated with risk, year 1+, 2+, 3+, but we also have some data that shows that rate of progression. So when tests are done serially, that the more rapidly, I think that's Paulo's data that shows the more rapidly the disease progresses, the greater the risk. So I think we do already have some.
Yeah, but you agree we need to have more data. We
yeah.
need to have more data from that and from IMT and other markers of disease, so it will be comprehensive.
course, you're only doing the analysis on people who survive to get the repeated measurements.
Yeah, but I think in that data, those people are followed, and we do have some outcome data for the people who are in each category.
Do we know the converse? I'm sorry to sort of raise.
No, this is not sorry. This is what we are here.
Do we know the converse of 1,000 patients who have an MI? What category are they in?
I want to ask everybody to answer. Harvey had some data presented in our meeting. Retrospectively, we all reviewed that paper in JACC, who John Rumberger nicely put in the slide, that these 250 people who died with heart attack, age 50 to 60, that very young group, and diabetes. The day before their heart attack, if you put them according to NCEP, you will find 72% categorized as medium risk, 83% categorized medium and low risk, which was shocking.
Based on risk factor.
Based on risk factor.
But what about based on
Disease.
positivity of disease?
Nobody
We don't know.
This was the question.
It's new.
Yeah, this was the question that, but
So-
Matt asked. Matt, go ahead.
No, I was going to say it's about 20% of patients were high risk, and about 80% were not high risk. Some were low risk.
Low risk or medium?
Or intermediate risk.
Medium. About 80% were defined medium and low risk, not a big red line, and I'm going to die tomorrow or have a heart attack tomorrow. This is what the major problem. Go ahead.
Now, was that based on Framingham? Or
Yes, framing it. Now, so the point here is the very important question, and that's the question actually PK put in his contribution, that the first thing we need to call for is, do we have a very clear distinction between the disease versus risk factor in the near future? Well, we all know, and there are some studies done in people who came with chest pain and did coronary calcium scoring, significant predictive value and sharp contrast. We know that, but we have to call for further research. And I think, Erling, this is one of the things that we need to take home here in perhaps a 1-page or 2-page, specifically call for certain really, I mean, this is not a proposal for a study, but it's a question that triggers a very clear path to design a study for, to answer that question. And that question is very critical for us. Thanks.
But then, of course, we need we want to risk or stratify the amount of disease in some way. Here we have 1+, 2, 3+. It's what we can do because it depends on the tool we are using. And here we need to find some threshold levels between 1 and 2+, and so it's arbitrary. It's a continuum in many situations. So it must depend on the tool we are using, how to stratify the amount of the disease and the amount of atherosclerosis.